Welcome back to the deep dive. Today, we are taking a structured look at something really critical and often misunderstood: substance use disorders, or SUDs.
That's right.
Our goal here is to kind of move past the casual way we sometimes talk about addiction. We want to arm you with the precise foundational knowledge that clinicians and researchers actually use.
And that precision is so important. We've pulled together source material that really lays out the formal classifications. These come from authorities like the American Psychiatric Association. They're really the gold standard for defining these conditions.
Exactly.
So we're going to use that as a roadmap, basically, to define the criteria for diagnosis and, just as importantly, explore the huge ripple effect these disorders have. We're talking about 8 major areas of a person's life.
Think of this as like your essential guide to getting really well informed quickly. We're not just going to list symptoms, we're digging into what those symptoms mean. We'll explore how these clinical frameworks categorize things, everything from being, temporarily impaired, maybe drunk or high, to developing a really chronic, life-altering condition. It's about moving from, I think the person has a problem, to really understanding the specific clinical points that define, say, a mild, moderate, or severe disorder.
And it's vital we start with those clear definitions because, these classifications help us get past subjective judgments. They get us a consistent language. Clinically, we don't just see one big problem, but rather a series of 4 related conditions when we talk about substance-related issues.
Okay, so let's unpack that clinical structure then. Our sources outline 4 key categories under this big umbrella of substance-related disorders. And the first 2, I gather, they describe the more immediate states, like related to the substance being there or just recently gone.
That's exactly right. We look at intoxication first and then withdrawal. These are temporary physical conditions, really, before we get into the more chronic disorders.
Right, so let's start with intoxication. Most people kind of get this one colloquially, right? Being drunk, stoned, loaded. But clinically, it sounds like it's more specific than that.
It is, yeah. Intoxication involves actual, measurable changes, both physiological in the body and psychological in the mind, that result directly from the substance being present acutely.
Okay.
Physiologically, the signs really depend on the drug type. So if we're talking alcohol or sedatives, you're likely to see signs of the central nervous system slowing down, things like slurred speech, maybe poor coordination. But then with stimulants, like cocaine, you might see the opposite effect.
Yeah.
Elevated blood pressure, maybe a rapid heart rate. And opioids, well, they typically cause noticeable drowsiness.
And what's happening psychologically during intoxication? Because it feels like this is where the immediate danger really ramps up.
Absolutely. Psychologically, we see pretty profound shifts, things like aggressiveness, irritability, significant disturbance of mood, and crucially, impaired attention and judgment.
Judgment, okay.
And this is where we really need to talk about something called executive function. These are the mental skills, that help us manage ourselves: working memory, thinking flexibly, self-control. Intoxication basically temporarily dismantles that executive function.
Right, so if your executive function is offline, essentially that explains why the clinical material draws such a direct line between being intoxicated and, really serious consequences.
Precisely. Intoxication isn't just feeling different. It's an acutely dangerous state because that impairment of judgment and self-control directly fuels things like violence towards others. All sorts of accidents. Driving is the obvious one, but also operating machinery or even suicide attempts. It's the immediate high-risk side of substance use.
Okay, that makes sense. Now let's shift to the second acute state you mentioned, withdrawal. So if intoxication is about having the substance in your system.
Withdrawal is what happens when it's suddenly taken away or significantly reduced. It's defined by those specific and often really unpleasant symptoms that pop up when you stop taking substances that the body's become physically dependent on. Think about things like alcohol or heroin. If someone's been using regularly, their body finds a new kind of chemical balance, sort of homeostasis with the drug present.
So pull the drug out, and that chemically induced balance just gets shattered.
That's a good way to put it, yeah. It's thrown completely out of whack.
Yeah.
The central nervous system, which has been working overtime to compensate for the drug, maybe a depressant, maybe a stimulant, suddenly finds itself completely unregulated.
Right.
So, for instance, stopping chronic heavy alcohol use, which is a depressant, can lead to the nervous system becoming hyperexcited. That's where you see tremors, severe anxiety, and sometimes even life-threatening seizures. It's the body basically rebelling against the sudden absence of that chemical crutch it got used to.
Okay, so we have these 2 acute states. Intoxication being under the influence, basically, and withdrawal, the physical fallout from stopping.
Yeah.
These describe temporary conditions. But the third category, and this seems like the real focus of our deep dive, is the chronic condition, the
Yeah.
substance use disorder itself.
Yes. And we also have that fourth category, which we'll definitely circle back to, the substance-induced disorder. That's crucial because it deals with psychiatric symptoms that pop up because of substance use, sometimes looking just like separate mental illnesses.
Right.
Creates a real diagnostic puzzle sometimes. Okay, so let's make that transition now from the acute states to the core chronic condition, the substance use disorder, or SUD. This is diagnosed when there's a fundamental pattern of use that leads to significant problems in life or real personal distress. We're shifting focus to the habitual destructive patterns now.
Right. So what's the clinical standard here? What's the minimum bar for actually diagnosing an SUD?
To meet the criteria for a substance use disorder, an individual needs to show 2 or more of the specific symptoms we're about to go through. And these symptoms need to occur within a 12-month period. Just 2.
Only 2. Wow. And what's really helpful, I think, is that the clinical view isn't just yes-no disorder, Minnesota disorder. It's a spectrum, right? The source material gives a clear severity scale, which must be vital for figuring out treatment.
Absolutely vital. The number of symptoms someone meets directly determines that clinical rating. It breaks down like this.
Okay.
If you meet 2 or 3 symptoms, it's considered a mild disorder.
Mild.
Meet 4 or 5 symptoms, and it's classified as a moderate disorder.
Moderate. Okay.
And if you hit 6 or more of those 11 criteria, that's considered a severe disorder.
Yeah.
And it's important to grasp that the difference between, say, moderate and severe often reflects just the sheer cumulative damage across someone's life.
We really need to break these 11 criteria down then. And using the specific examples from the source material seems key because honestly, they make these clinical terms feel incredibly real, very tangible.
They do.
For clarity, maybe we can group them. Let's start with the criteria that seem focused on loss of control.
Yeah, that's a good way to group them. This first set really speaks to that psychological aspect, that feeling of defeat almost. That's so common in SEDs, basically. The inability to manage the substance, even when someone is desperately trying.
Okay, so criterion 1, loss of control. The definition seems straightforward, using more of the substance or using it for longer than the person originally planned.
Exactly. It highlights that disconnect between what someone intends to do and what actually happens. Look at the examples given. Ron buys a bunch of marijuana, fully intending it to last him weeks, but then he finds himself smoking it all in just a couple of days.
Right.
Or Lisa, who keeps telling herself, okay, just a couple drinks at this party, but invariably ends up getting drunk every single time. It's like the substance itself starts dictating how much and how long, overriding the person's own conscious plan.
It's like the substance grabs the steering wheel, which leads pretty naturally to criterion 2. Can't cut down or control use. This seems to be about a persistent desire to quit or cut back, but coupled with unsuccessful efforts.
This one really captures that heartbreaking cycle of hope and relapse that you see so often in chronic addiction. The source gives that stark example of, Dennis, he's quit smoking 10 times in the past few years. Sometimes he manages a few days, sometimes even up to 3 months, but he always goes back.
Wow.
The desire to stop is genuinely there, but the ability to actually sustain stopping just isn't.
And that failure can be immediate and devastating, like in the example of Liz with crack cocaine.
Yeah, that's a powerful one. Liz buys a rock, she checks her money, she consciously tries to set limits for herself. But the drive, the compulsion is so overwhelming that she just keeps buying more and more until all her money is gone. This isn't just about physical need, it's like a psychological hijacking of her self-control or financial sense, everything.
Okay, then criterion 3, preoccupation or compulsion. This is about spending a lot of time getting the substance, using it, or recovering from its effects. This feels like it measures the opportunity cost of the disorder, right? What else isn't getting done?
Precisely. This is where you see the substance become the absolute center of someone's life. It starts consuming their most valuable resource, their time. Think about Sandy, the nurse in the example. She's spending considerable time, mental energy, planning these elaborate, risky ways to steal drugs at work. The sheer brain power focused on that one task is enormous.
And it's not just getting the drug, it's structuring life around it, like with Stephen.
Yeah, Stephen plans his whole workday, specifically so his evenings and weekends can be almost entirely dedicated to getting high. Any potentially productive or meaningful downtime just gets sacrificed. And when you add in the time actually spent intoxicated or recovering the next day, the substance can easily eat up half or more of a person's waking hours.
Wow. Okay, the last one in this loss of control group seems to be criterion 4, craving, defined as a strong, intrusive desire or urge to use the substance.
And craving is fundamentally different from just wanting something. It's this intensely powerful physiological and psychological compulsion. It can be incredibly disruptive, even when someone hasn't used it for a while. Like Jack in the example hasn't had a drink in weeks, but still feels those powerful cravings almost every single day. The brain chemistry is still out of balance.
And the example of Jessica really drives home that internal battle.
Right. Jessica stopped using pain pills. Intellectually, she knows going back would be disastrous, worsen her addiction, undo all her hard work. But she still feels these overwhelming desires to get some. The craving becomes this persistent internal enemy she has to fight constantly.
What's really striking here is realizing someone doesn't even need to hit tolerance or withdrawal, the physical stuff, to potentially have a severe substance use disorder. If someone meets just these first 4 criteria and they're intense.
They're already at 4 out of 11. That puts them squarely in the moderate range, potentially heading towards severe very quickly.
Yeah, so the loss of control and the way it messes up your life, that's just as clinically significant as physical dependence.
Absolutely. The behavioral and psychological components are critical indicators. Okay, so moving on to the next batch of criteria, these 5 really illustrate the external damage. They focus on how the disorder starts to erode a person's ability to function responsibly in the world and maintain healthy relationships.
Right. So, criterion 5, failure to fulfill major obligations. This leads to recurring problems at work, home, or school. Seems pretty direct.
It captures that basic breakdown of responsibility. Look at Chris. His cannabis use directly led to bad grades and eventually dropping out of college. That's a clear failure to meet a major life obligation. Or on the family side, Megan, who consistently relies on her teenage daughter to babysit the younger one while she goes out drinking, often staying out very late. She's fundamentally failing in her basic parental duties.
Okay. Then criterion 6, continued use despite relationship problems. This is about recurring social or relationship issues that are either caused by the substance use or made worse by it.
This one highlights the conflict and chaos the substance injects into a person's social life. Like Dan in the example, who actively starts fights in bars or at parties when he's drunk. It's not just passive neglect. It can be active, aggressive disruption.
And the sheer emotional weight of this is clear in Rebecca's situation.
Yeah, Rebecca feels like she's ruining her marriage. Her husband won't get help for her addiction, and she's aware of the distress, the damage her continued use is causing. But the compulsion to use is still stronger than her desire to save the marriage. That internal conflict must be immense, yet the use continues.
Then criterion 7, psychosocial impairment. This is about giving up or losing important activities, social, work-related, recreational, specifically because of the substance use. This feels like life just starts shrinking.
That's a great way to put it. The substance actively replaces other meaningful parts of life. It's a loss of identity, really. Melissa lost 2 jobs because of absences due to drinking. Okay, that's occupational. But the source also notes she quit swimming and playing tennis. These were healthy, defining activities for her, just swapped out for drinking and recovering.
And Leonard's example is just devastating, showing how future opportunities can collapse.
Absolutely. Leonard gets kicked off the football team after testing positive for drugs multiple times. That didn't just cost him his sport, it cost him his scholarship, which led to him dropping out of college entirely. The substance basically erased his whole planned future, his potential career path.
Okay, now we shift focus a bit towards criteria centered on risk and health. Criterion 8, use in hazardous situations, using substances in situations that are physically dangerous.
This points to a really profound impairment in judging risk. Raul, using stimulants to stay awake while driving long distances, he's deliberately mixing drug use with a high-stakes activity, essentially gambling with his own life and potentially others, all to keep going or keep using.
And the example of Patricia, who drives home after drinks, that highlights something common but so critical, the distorted perception of safety.
Yeah, Patricia has several drinks, but she doesn't feel drunk, so she rationalizes, oh, driving's fine. This illustrates a key concept, often seen in SUDs, called anosognosia, basically, a lack of insight or awareness into one's own condition and the immediate risks it poses. The substance itself warps the feeling of impairment, leading to incredibly reckless choices.
Which leads us to criterion 9. Use despite negative effects. Continuing to use even when you know that a physical, psychological, family, or other serious problem is likely to happen, or is already happening because of it.
This might be the most profound sign of how tight the disorder's grip is. The compulsion literally overrides basic survival instincts. Don keeps drinking even after his doctor explicitly warns him repeatedly that his liver is already damaged and continuing could kill him.
And the same logic, or lack thereof, is seen with Roberta and smoking.
Exactly.
Mm.
Roberta smokes 2 packs a day despite severe chronic respiratory problems, and her doctor strongly advising her to stop. The knowledge of serious self-inflicted harm is right there, clear as day. But the drive to use is so powerful it just bulldozes over self-preservation. It's a really tragic breakdown of the self.
All right, finally, we get to the last 2 criteria. These focus on those core physiological changes that traditionally define physical dependence: tolerance and withdrawal.
Yes, these are the markers that people often think of first when they hear addiction, although, as we've seen, clinicians now recognize that the behavioral criteria, those first 9, are just as, if not more, critical for making the diagnosis.
Okay, so let's talk criterion 10, tolerance. This means either needing more of the substance to get the same effect, or finding that the same amount gives you less effect over time.
Right, and it actually breaks down into 2 distinct ways this can show up. Criterion 10A is increased tolerance. This is the classic picture. John used to get a buzz from 2 or 3 drinks, but now he needs 6 or more just to feel that same effect. His body has adapted chemically to neutralize the substance, so he needs bigger doses to achieve the original high.
And this adaptation forces users like Wanda to escalate things pretty dramatically.
Yeah, Wanda used to take 2 Valium, now she's taking 6, and often mixing in other tranquilizers or even alcohol just trying to get back to that initial feeling. Tolerance drives up the physical danger because people end up chasing that first high by consuming increasingly toxic amounts.
Okay, that makes sense. But what about criterion 10B, decreased tolerance? That sounds backwards. Doesn't addiction always mean needing more?
That's a really sharp question, and it points to something often seen in very advanced, severe stages of the disorder. Decreased tolerance often means the body's systems, maybe the liver's ability to metabolize the drug, or even the brain receptors themselves have become so damaged by chronic, heavy use that they just can't process the substance effectively anymore. Or the receptors are just overwhelmed, maybe permanently damaged. The system is essentially burned out. Exactly. Like Delinda, who used to drink a pint or more daily to feel that buzz. Now she drinks the same amount, but the buzz just isn't there anymore. Or Alfonso, using large amounts of opiates, alcohol, tranquilizers, he just doesn't get high from the same quantities anymore. It's like the capacity for euphoria itself has been blunted or even destroyed by the constant presence of the substance.
Wow. Okay. And finally, criterion 11, withdrawal syndrome.
This one also splits into 2 important parts reflecting that physical reaction. Criterion 11A is experiencing the actual withdrawal syndrome itself when the substance is stopped or cut back.
Right, like Michelle stopping alcohol and getting nauseous, anxious, shaky, those classic signs of an overexcited nervous system kicking back. Or Russ stopping heroin, getting those awful physical symptoms: stomach cramps, diarrhea, runny nose, goosebumps. These are very specific, predictable, and often dangerous physical reactions tied directly to stopping that particular substance.
And that horrible experience leads directly to Criterion 11B. Using the substance specifically to avoid or relieve those withdrawal symptoms. This is where the motivation can shift entirely. It's not about seeking pleasure anymore. It's purely about avoiding pain.
This is the maintenance cycle kicking in, like Betty taking tranquilizers constantly, not really to get high, but just because she knows she'll get physically sick if she stops.
Exactly. Or Dean having those few belts of whiskey in his coffee every morning just to stop the shakes to get himself settled enough to face work. Then he needs a few more drinks at lunch just to keep the withdrawal at bay. His whole day becomes dictated by the chemical need to prevent feeling physically ill. That's pure functional physical dependence right there.
So we've mapped out all 11 symptoms, covering loss of control, functional impairment, social problems, risk-taking, and finally the physical dependence markers. And just meeting 2 of these over a year establishes a substance use disorder diagnosis, with the number indicating how severe it is. It's a really comprehensive way to see when substance use crosses the line into a chronic, destructive pattern.
So having sort of nailed down that chronic pattern of use, the SUD itself, we absolutely have to discuss that 4th category we mentioned earlier. Substance-induced disorders. This is where things get really interesting and sometimes complicated because we're looking at how chronic substance use can actively confuse the picture by mimicking primary psychiatric illnesses.
Yeah, this is fascinating. It's not just that alcohol and drugs mess up your life externally, but they directly impact the brain's chemistry and structure, right? Which is where all our moods, anxieties, thoughts come from.
Precisely. Chronic use, is like throwing a chemical monkey wrench into the incredibly delicate machinery of brain chemistry. It can directly cause, or certainly magnify, existing conditions like mood disorders, anxiety disorders, even psychotic disorders. Someone might show up presenting with severe depression or panic attacks, or even paranoid thinking that looks, for all the world, like a textbook psychiatric illness.
But the critical distinction, and this sounds like it requires real clinical patience, is figuring out where those symptoms are coming from. Is the severe depression, say, a standalone illness needing its own treatment? Or is it actually just a symptom of the chronic substance use itself?
That is the absolute core diagnostic challenge here. The source material really emphasizes that these substance-induced symptoms, the depression, the anxiety caused by the drugs, might actually clear up completely if the person achieves sustained abstinence. But it often takes time, several weeks, maybe even longer, for the brain chemistry to start renormalizing after being constantly exposed to the substance. So if that depression or anxiety fades away during this period of sobriety, it was likely substance-induced.
And why is that waiting period, those several months, why is that so tough in practice?
Well, think about it. The person is not only dealing with the often intense discomforts, detox, and early withdrawal symptoms, but they're also experiencing this severe mood disturbance at the same time. They feel absolutely terrible, anxious, maybe deeply depressed, hopeless. And clinicians have to resist the temptation to immediately jump in and medicate what might just be a temporary chemical imbalance as the brain slowly heals itself.
Right, because if you rush to treat depression, that's actually caused by the substance.
You might end up putting someone on a long-term psychiatric medication they don't actually need, potentially creating a whole new set of issues or dependencies. It requires careful observation over time.
Let's look at the two examples the material provides because they really illustrate this difference clearly. First, there's Matt. He got severely depressed, even suicidal, after several weeks of heavy cocaine use.
Yeah, Matt's case is a perfect example of the substance-induced scenario. Cocaine provides this massive artificial rush of neurochemicals like dopamine and serotonin. The crash that inevitably follows heavy use is a profound depletion of those same chemicals. So when he stopped the cocaine, the severe depression he felt was, in large part, the direct predictable chemical consequence of that crash.
Okay.
As he got into recovery, stayed off the cocaine, his body's chemistry started to rebalance, and his mood improved significantly. He likely didn't need long-term antidepressant medication for that specific episode.
Now contrast that with Shannon. She stopped drinking alcohol and using tranquilizers, but while she was sober, she actually became more anxious and depressed.
Shannon's case is likely pointing towards what we call co-occurring disorders, or sometimes dual diagnosis. Her substance dependence, her drinking and tranquilizer use, was probably her way of coping her attempt to self-medicate pre-existing underlying anxiety and depression that were there before the heavy substance use really took hold, or at least independent of it. So when she removed the substances, the medication she was using, the underlying independent mental health condition was unmasked, it came roaring back. Shannon would likely need integrated treatment that addresses both her SUD and her primary anxiety and depression. Making that distinction between Matt and Shannon is absolutely crucial for developing an effective, targeted recovery plan.
Okay, so we've got the clinical definitions, the diagnostic criteria. Now let's shift focus from diagnosis to impact. Once that pattern of use is established, even if it's only clinically mild, what does the source material tell us about just the pervasive, corrosive effect it has on someone's actual life?
The overview is pretty stark. Substance use, whether directly or indirectly, contributes to problems across almost every single area of a person's existence. We're talking serious medical issues, spiritual distress, psychological pain, psychiatric complications, family breakdown, and major economic problems. The sources force us to look way beyond just the most obvious failures, like losing a job or getting arrested.
Yeah, I found that example of the attorney really eye-opening because it highlights how subtle the damage can be sometimes, especially with people who seem, high-functioning. The consequences can hide in plain sight.
That example really challenges the stereotype, doesn't it? Initially, this attorney's drinking didn't lead to her losing a big case or getting fired outright. On the surface, her work seemed okay, but when her supervisors took a closer look at her actual productivity metrics specifically, her billable hours, they found a significant drop, a decrease of 15 to 20%.
Wow.
The substance was silently eroding her capacity, her effectiveness, or profitability long before any big dramatic crisis erupted. That lost productivity, that's a very real, measurable economic consequence, even if it's hidden.
That economic and functional cost is one thing, but the source material really emphasizes the social and emotional cost, particularly within the family. Let's dive into that family impact.
Yeah, the burden on families is often described as just tremendous, and it hits on so many levels. You see really negative outcomes, like the complete loss of family relationships, separation, divorce,
Hmm.
or tragically, the involvement of child protective services, often because basic needs like food, shelter, clothing for the kids are being neglected.
And the economic strain on the family just piles on top of everything else, right? It's not just the money spent on the substance itself.
Not at all. The financial drain comes from really three things happening at once. First, yes, spending family money directly on the drugs or alcohol. Second, lost income because of problems caused by the use, missing work, getting fired. And third, all the associated costs that rack up legal fees, emergency room visits, maybe psychiatric care. It can completely destabilize a household financially.
And beyond the money, there's that huge, often invisible emotional toll on spouses, partners, children.
The whole emotional climate of the home can become toxic. Family members are often living with constant anger, fear, worry, deep distrust, and often depression themselves. The neglect, or sometimes abuse or violence that can accompany SUDs, creates this perpetual state of uncertainty, maybe hypervigilance, within the family system. It's incredibly stressful.
And this leads to a really crucial long-term point the source material raises.
Yeah.
This idea of generational vulnerability.
Yes, the cycle of transmission. Substance use disorders make it incredibly difficult for parents to function responsibly, to provide that stable, nurturing environment children need. This damages the parent-child relationship fundamentally.
Okay.
And then compounding that, if the child also happens to inherit a genetic predisposition towards SUDs, which we know can happen growing up in that chaotic environment, with a parent actively using, significantly increases their risk of developing their own substance use problems later in life. That's why family-focused interventions are so critical. It's often about trying to break that destructive generational pattern. Hashtag Tag Dave 106. Deep dive into the 8 consequence categories. Box 3.1, Worksheet 3.1.
Okay, we really need to systematically walk through these 8 major areas, these consequence categories that the source material lays out. This seems to draw from broad clinical experience, National Institutes of Health findings. This is where we really grasp the full scope of the damage, right?
Exactly. This framework helps organize the chaos in a way. Let's start with 1, medical and health. This is often where the most immediate and sometimes final consequences show up.
Right. Beyond the obvious acute risks, accidents, injuries, overdose, the chronic damage seems really insidious. Poor nutrition, poor hygiene seem almost universal consequences, leading to really specific things like terrible dental health, lost teeth, gum disease, and significant weight changes, either gaining a lot or losing a dangerous amount depending on the substance.
And the chronic breakdown of body systems is just staggering. Substance use significantly bumps up the risk for specific severe illnesses. The source highlights damage to the liver, heart, kidneys, lungs. Alcohol, for example, is a major known cause of cancers in the mouth and throat, gastritis, fluid retention or edema, and chronic high blood pressure.
It's also worth just briefly touching on the indirect health risks again. We talked about impaired judgment leading to accidents, but it also often translates into increased risk for sexually transmitted diseases. HIV, hepatitis B and C are specifically mentioned, usually linked to high-risk sexual behaviors that happen during intoxication.
That's a critical point.
So the substance doesn't just damage your organs directly, it drives behaviors that compromise your overall health and, frankly, how long you'll live.
Okay, moving to 2, emotional consequences. Now, we already talked about substance-induced disorders mimicking psychiatric illness. This category is a bit different. It's more about the persistent emotional instability and pain that comes just from the reality of living with a chronic self-destructive disorder.
Right. And the range of emotions sounds intense. Constant anxiety, panic reactions, ongoing depression, really extreme and unpredictable mood swings, and sometimes even persistent psychosis. And internally, the person is often battling these overwhelming feelings of shame and guilt, leading to really low self-esteem.
And that internal turmoil frequently spills outward in very dangerous ways. We see feelings of intense anger or rage, totally unpredictable behaviors, aggressiveness, sometimes violence towards others, and tragically, the whole spectrum of suicidal thoughts, feelings, or actual attempts and completions. The emotional landscape for someone deep in an SUD is often like a constant state of emergency, fueled by shame, desperation, and the substance itself.
Okay, next is 3, work school. This hits right at the foundation of well, being able to support yourself and function in society.
Yeah, the consequences here are often immediate and can really alter someone's future path. Consistently poor performance is common. Then there's the eventual loss of jobs or dropping out of school. The person becomes unreliable, frequently late or absent, and just generally less effective even when they are present.
And the long-term cost here can be huge. We mentioned Leonard losing his football scholarship earlier. That wasn't just losing a sport, it represented a ruined career path, opportunities just slammed shut, potentially forever. The addiction doesn't just cost money now, it can erase an entire future income stream.
Absolutely. Category 4, family consequences. You mentioned the burden earlier, and this is where the disorder's destructive power often feels the most personal and painful.
We see the actual breakdown of the family unit. Separation, divorce, the really painful involvement of child welfare agencies. Conflict and distress within the family become the norm, the default setting. The person with the SUD often just can't fulfill their role as a parent, leading to kids being raised by grandparents, other relatives, or ending up in foster care.
And we really can't overstate that emotional burden we talked about. The constant anger, the hurt, the deep distrust, the fear, the worry, the depression that ripples through all family members. The source material specifically points out how poor communication, often driven by secrets, denial, conflict, actually helps perpetuate the environment that can contribute to substance use problems cropping up in the children later on. It's truly a multi-generational crisis in many families.
Okay, we differentiate that slightly, it seems, when we look at 5, interpersonal relationships, which focuses more on the social circle outside the immediate family.
Yes, exactly. This covers things like losing or severely damaging friendships, having ongoing conflicts with coworkers or acquaintances, just general dissatisfaction in those broader relationships. But perhaps the most profound consequence listed here is the erosion of trust and respect from significant others, friends, mentors, colleagues. This destroys the social safety net most people rely on. So when someone finally does hit bottom and maybe wants help, they often find they've burned every bridge they needed to get across.
That's a grim thought. Okay, moving to 6, recreational loss. This might seem less serious than, say, liver failure or losing your family, but the source is listed as a major consequence area. It must be important for overall well-being.
Oh, it's critically important for mental health and just having a sense of identity. This is about diminished interest in or completely giving up important hobbies, passions, social activities, leisure pursuits. When the substance takes over someone's life, it tends to become the single primary source of reward and focus. Everything else, fishing, painting, playing music, team sports, volunteering, whatever it was, just falls by the wayside.
Life shrinks.
Life shrinks dramatically until it's almost entirely centered around obtaining, using, and recovering from the substance. And that isolation itself is a huge risk factor for relapse later on.
Okay, second to last, 7, legal problems. These often seem like the most tangible, external signs that things are out of control, stemming from that impaired judgment we discussed.
Definitely. This category covers a huge range of negative consequences with the justice system. Everything from relatively minor stuff like fines or other legal constraints, all the way up to severe outcomes like arrests, convictions, actual jail or prison time, and then the long-term burden of probation or parole hanging over someone's head. These legal consequences can follow a person for decades, affecting their ability to get housing, find employment, even vote, long after they might have achieved sobriety.
And finally, 8, economic consequences. It feels like these problems often snowball from all the other 7 categories, creating this downward spiral.
That's often exactly how it works. The material loss is usually immediate and significant. Loss of income from job problems, racking up massive debts, maybe through spending on the substance, maybe through gambling or impulsive decisions made while intoxicated. People inevitably fall behind on bills, ignore financial responsibilities.
Right.
Then there's the potential loss of basic security, losing housing, stable living arrangements, and tragically, sometimes reaching the point of being unable to cover basic needs like food or shelter because every single penny is going towards the substance.
And what's interesting is the source includes the behavioral aspect, too.
Yeah.
The inability to manage money effectively anymore, and the complete failure to save or plan for the future. The substance doesn't just dominate present spending, it destroys any capacity for long-term financial thinking or recovery. The future is constantly being sacrificed for the immediate need or craving. Hashtag tag 7. Oh.
So this deep dive has really walked us through the clinical bedrock of understanding substance use disorders. We started with those immediate acute states, intoxication and withdrawal. We moved through the detailed 11 criteria that clinicians use to define the presence and severity of an SUD. And we just finished outlining the incredibly extensive life-shattering consequences across those 8 major domains of life. I think the core takeaway is just how comprehensive, how pervasive this illness is. It truly erodes life on almost every single front.
And this structured understanding, pulling directly from clinical source material, it's not just for professionals, it's powerful for self-reflection too. The source material we looked at actually included tools worksheets 2.2 and 3.1 are mentioned that are designed for self-assessment, prompting you, the listener, to really think about your own current level of harm, maybe, and your readiness to make a change.
Exactly. Because recognizing the clinical shape of the problem, understanding the diagnosis, that's really only the first step on the journey. The next step, and you could argue it's the most critical one, is assessing the internal resources someone has to actually make and sustain change. The workbook specifically prompts users to rate themselves on 3 key psychological areas, using a scale, usually from 1 to 7.
Okay, so this really brings it back to the listener. It raises an essential question for you to think about, to mull over. If you were to honestly consider these 3 core factors, first, the severity level of the problem, thinking back to those 11 criteria, would you rate it as mild, moderate, serious, or even extremely severe? Second, your motivation level to quit, where do you fall on a scale from definitely don't want to quit all the way up to extremely strong desire to quit? And third, your confidence in your ability to stay sober. How confident do you feel? From low confidence right up to very high confidence. How would you rate those 3 factors in your life right now, or perhaps in the life of someone you care about?
Those 3 internal factors, severity perception, motivation, and confidence, they're really the core engine of recovery potential. Understanding the clinical diagnosis gives you the map, absolutely. But whether someone successfully navigates that map towards lasting change depends fundamentally on that interplay between how serious they recognize the problem to be and their own internal drive and belief in their ability to achieve and, crucially, maintain sobriety. It really boils down to an active will, but an active will that's informed by knowledge.